but to be, I shouldn't leave the meeting, I guess. Thank you, Cheryl, for the kind words, but I would say my expertise probably just goes to Bloor Street, Yonge Street, and probably the Don Valley. So thank you anyway. I think the last time I presented at these rounds was probably prior to my starting at Sunnybrook, and I actually talked about prostate cancer, and I had no gray hair. So a lot of things have happened since then. But thank you for giving me the opportunity to speak to you, at least virtually, although not in person. Yes, so the talk is entitled "A 2 Decades of Progress." And the picture you see in front of you is actually the first patient that was treated with imatinib by Dr. George Dimitri at the Dana-Farber. And you see on the left, the patient had an FDG PET scan, which shows FDG uptake in multiple areas of metastatic sites. And then just a little while after being treated with imatinib, the tumor sites went pretty cold. And this was published in 2001. And I do recall being at a meeting with Dr. Dimitri just around 1998 when he was starting to look into TKI treatment of GIST, and although he could not say it, he was very excited about the results that he was seeing. Or I think it was probably after 98. So I have to thank this fellow who you know very well. It's Dr. Law, and I have to thank him too, as he's the one who actually led me to going into this field of GIST. He said, hey, there's only really one drug. It's pretty simple. You're a simple guy. I think you can do it. So that's why I'm here. And I have no specific disclosures to say. So I wanted to sort of outline what's happened with GIST over the last 2 decades. And I think it really spans the career of Roger Federer in terms of timing, since he just recently retired. And just in July of 2001, I think Pete Sampras was hoping to get one last Wimbledon, but a young fellow named Roger Federer took him out during the 4th round. And although Roger did not win Wimbledon, I think it was just the start of his burgeoning career. And this is when GIST really started to make great progress. So the first paper published was in 1998 in Science, where Hirota actually published sequencing of 5 patient samples with GIST, in which case he described mutations in the justa membrane area of c-KIT. And they were able to actually transfect this into a mouse lymphoid line and make these into a malignant cell line, thereby sort of establishing the pivotal role of this gene in the pathobiology of GIST. So 1998. So today I'll go through a little bit about the background of this fairly rare cancer, sort of outline the molecular changes that have been described in this tumor, describe the progress that's made in adjuvant therapy, as well as in metastatic disease. And I'll describe the pivotal studies in advanced disease, mostly focusing on the positive studies and not the negative ones. And I'll go into a couple cases, if there's time, to describe some of the non-systemic approaches that can be integrated in the care of a patient with GIST. So gastrointestinal stromal tumors are not common cancers, and the putative cell of origin is felt to be the interstitial cells of Cajal, which you see in the pictogram on the right. And these are the pacemaker cells of the GI tract. And and it's felt to be the cell of origin, given that they are both positive for CD117 or KIT, as well as CD34. And what's been described is a frequent gain of function in c-KIT in gastrointestinal stromal tumors, which leads to sort of always on state for this growth factor receptor pathway. And prior to sort of 2000, 2001, unresectable or metastatic disease was uniformly fatal for those who were diagnosed with it, because there was no response to conventional chemotherapy such as doxorubicin, which has been used in other sarcomas, or any radiation therapy. And before 2002, the median survival was really about 20 months. The cases vary according to where you look in the world, and there can be about 15 cases of GIST per 1 million adults. It constitutes about 1 to 3% of all malignant GI tumors. The median age is sort of late 50s, just a little more common in males versus females. And what that amounts to in Canada is probably about 500 new patients a year that we see. Although it is not one of the common cancers in the GI tract, it is actually the most common sarcoma. As you can see in orange, just comprises almost 1 in 5 patients who are diagnosed with the sarcoma, the rest being a mix of leiomyosarcomas, rhabdosarcomas, angiosarcomas, and the care of which is really has been regionalized to sarcoma centers such as the Sinai. Oh, let's see. In terms of location, the most common location of GIST tumors is in the stomach. The second most common being small intestine, the rest being very uncommon, so colorectal or large bowel in 5%, and esophageal in less than 1%. And what we call extraluminal is really very uncommon, I would say less than 1%. So what we see is rectal GE junction GISTs, as well as small bowel and gastric GISTs. Those are the most common. They most commonly present as an upper GI bleed or a non-painful palpable abdominal mass, depending on how big the tumor actually gets before the time of diagnosis. There are different types of GIST histologically. The most common is the spindle cell type, which you can see the cartoon of just on the top. The epithelioid or round cell type is not as common as depicted on the picture on the right. There can be those that are mixed one or the other, so mixed GISTs. Really probably doesn't have a huge prognostic view, so it's not, I don't think it's the same as ductal or lobular breast cancer, but there are two different histologic patterns. The sizes can vary from small tumors measuring less than 2 centimeters, or what we would consider to be microGIST, to really gigantic masses that are over 10 centimeters. I've certainly seen patients who have very large tumors, even bigger than the size of my head, and I have a pretty big head. And approximately half the patients present still with metastatic disease, despite patients undergoing cross-sectional imaging at an earlier time. In terms of how the cancer metastasizes, liver is probably a common site of metastases, as well as the peritoneum. What we don't see are extra abdominal disease, such as lung metastases, CNS metastases. And one thing that's not common for most patients with GIST is lymph node metastases are not common. And as a result, when the surgeons go in, they do not do an extended lymphadenectomy. There is a caveat to that. Those with tumors that are not KIT related or PDGFR related are more what we would conventionally describe as wild type in the older days, can present with nodal disease. What characterizes GIST is the molecular aberrations that have really been described over the past 20 years, and a lot of work has been done, and this has really been the poster child of druggable targets for cancers. And the most common are mutations in KIT, and the KIT is a membrane based growth factor receptor, of which stem cell factor, or SCF, is the ligand. And what happens is the mutations are often seen in the juxtamembrane domain, or in exon 11, which is seen in about 2/3 of patients with GIST. The second most common is in the extracellular domain of the receptor, or exon 9, which is seen about 10% of GIST patients. The other mutations that are seen in KIT are those that are in the ATP binding domain, or the activation loop, i.e. those are the ones that are being that have mutation in exon 13 or 17, but these tend to be what we call secondary mutations after being on treatment. The other growth factor receptor is the platelet-derived growth factor receptor alpha, and this shares homology with KIT. And the ligand here is not stem cell factor but PDGF, of which the most common mutation is in exon 18, is actually in the activation loop, which is seen in 5% of GISTs. The other ones in the juxtamembrane domain, as well as the ATP binding domain, exons 12 and 14, are really uncommonly seen. So the exon 18 mutation is typically D842V mutation that has traditionally been difficult to treat with the TKIs that we have. The tumor mutations are seen more commonly in certain areas of the GI tract. So, for example, those with the PDGFR exon 18 mutations usually have tumors that arise from the stomach, whereas those with exon 9 mutations are more commonly seen in the small bowel, whereas those with exons 13 and 17 of KIT, or exon 12 of platelet-derived growth factor, or other what we call wild type GIST can be seen anywhere in the GI tract. Chris Corliss, pathologist in, I believe, Oregon, has done a tremendous amount of work in this disease, and he actually thinks that this actually may represent at least 10 different molecular phenotypes, and those include ones with exon 11 KIT mutations, exon 9, the other KIT mutations, the platelet-derived growth factor receptor mutations that are either exon 18 or other exons, NF1 or neurofibromatosis 1, those with BRAF mutations, or those with the mutation in the RAF pathway, or SDH. Others have been seen as IGF-1 receptor overexpression, which has been typically fallen into the wild type category. They do behave differently. For example, I think the graph on the left shows that those with exon 9 mutations, which are about 1 in 10 patients with GIST, generally do a little bit worse compared to other mutations, especially when treated with a standard dose of imatinib, which is 400 milligrams. So what about targeted treatments for GIST? As I said, in 2001, the EU approved imatinib, otherwise known as Gleevec at that time, for KIT-positive, unresectable, or metastatic GIST. Since then, it's been approved for adjuvant therapy for KIT-positive tumors in both the US, EU, as well as Canada. And imatinib is a drug that came really out of the CML BCR-ABL field. And what it does is it prevents binding of the protein substrate, and it prevents constitutive activation of KIT as well as PDGF receptors mutations as a result of driver mutations affecting this tumor. So in terms of adjuvant therapy for GIST, this moved really quickly once the drug imatinib was established in advanced disease, and I'm going to try to address that first. And this is a trial that was done between a period of June 2002, over a 3-year period to April of 2007. And during that time, this is really probably Federer's most important era, where he actually won 10 Grand Slams, and that includes 3 Australian Opens, 4 Wimbledons, and 4 US Opens. And if the trial had gone to July 2007, we would have changed the 4 Wimbledons to 5 Wimbledon championships. The surgical group in the US launched the adjuvant trial again in 2002, where they took patients who had tumors that were resected that measured 3 or more centimeters. And if they were KIT positive, they were randomized to either placebo or imatinib for 1 year. And 713 patients were enrolled over this time. Again, they did not use the other prognostic factors that we know are important in GIST, that is the number of mitosis, or the tumor that it actually, the organ that it actually started in. And the reason for that was, at that time, mitotic figures and its reporting was inconsistent across all the institutions, so they did not feel that it was as reliable, so they went by size alone. And so in April of 2007, the trial was stopped early, and the NCI released this statement that showed that based on this trial, that if you got imatinib for 1 year, you were significantly less likely to have a recurrence compared to those who did not receive imatinib, with the hazard ratios being really probably, I think I recall, being around 0.3 or less. Since then, 2 large trials have been reported, and this is probably the most important trial, or what we refer to is the SSG trial. And they took a different population of GIST patients who had an operation. They took what would be considered to be high-risk patients and randomized them to 3 years of imatinib versus just 1 year, and no placebo. And what this showed was that the recurrence-free survival was significantly better for 3 years of imatinib versus 1 year, with a hazard ratio being 46.46. And
having to wait for like,
oh, that's okay. And despite this, despite overall survival not being a primary endpoint, this showed that there was actually a 55% reduction in risk of death if you were treated with 3 years of imatinib. They did do a follow-up 10 years later, and this showed that that the benefit to really persisted with longer follow-up, although the hazard ratios are a little more modest, with really a 34% reduction in recurrence and overall 45% risk decrease in risk of death. And so what they concluded with the prolonged follow-up from the SSG trial was that 1/2 the deaths were avoided with longer treatment of 3 years versus really 1 year of imatinib for those with high-risk disease. Another trial that was published in just about 8 years ago was the another European trial. And this was a trial that randomized patients to 2 years versus placebo. This trial underwent a number of changes during its conduct, and in fact, the primary endpoint was changed from overall survival to imatinib failure-free survival, and that's what IFFS stands for. And when they looked at this patient population, and this was really, I believe, an intermediate to high-risk patient population, the IFFS was not statistically different between the 2 arms, although the relapse-free survival clearly favored the 2 years of imatinib. There was no difference in overall survival. And the reason for this is probably patients respond quite well at time of recurrence to imatinib, and for this trial, patients were only on it for 2 years rather than 3 years. So when they did recur, they were quickly placed on imatinib and had control of their disease. Is there a study that looks at longer imatinib treatment? There is, but unfortunately, it's a single-arm study, and this was a US-based trial where they took patients with intermediate or high-risk GIST and treated them with 5 years of imatinib. And the take-home message from this trial is that about half the patients actually discontinue imatinib earlier than 5 years, and that's because of side effects. And from this trial and the patients that were treated on it, the estimated 5-year relapse-free survival is very high. It was 90%, and the overall survival was 95%. The other learnings from this trial is that the 7 patients who recurred on this trial all recurred really at less than 2 years after stopping the medication, as you can see in the bar graph seen above. And so really the risk of recurrent, the risk period is within 2 years of stopping. And there's really only 1 patient who relapsed after immediately stopping or who had been on imatinib a very short time. Here, I'm just going to move this. So now the problem that's been rising is that the drugs that we have don't have activity against some of the secondary mutations, which accounts for emerging resistance while they're on imatinib therapy, as well as other kinase inhibitors. And again, as I stated, for c-KIT, it's usually exon 17 or 18, which is in the activation loop, and occasionally in the ATP binding pocket of encoded by exons 13 and 14. This is on the right. You'll see some of the drug sensitivities suggesting that the for example, the N822 mutation exon 17 of the activation loop, the sensitivities are of imatinib sunitinib is certainly suboptimal compared to regorafenib. Overall, with imatinib, the survival has been excellent. So what you see in the yellow graph is a historical comparison of doxorubicin in metastatic disease, in which case the median survival is really less than a year. But the long-term data from the imatinib trial suggests that the median overall survival is about 5 years with TKI treatment. However, there is emergence of resistance based on some of the molecular studies that have been done. It is a little different depending on the types of mutations you have. So obviously exon 9 as well as wild type tumors behave differently with earlier recurrences than with exon 11 mutations based on imatinib treatment, although the survival is really much better than pre-imatinib. So what causes the resistance to TKI? Again, mutations in the secondary mutations in exon 17 and 18. Can we target these mutations through an alternate signal transduction pathway? And that's been sort of the avenue of investigation since imatinib. So in terms of resistance, we should describe the differences between what's considered to be primary and secondary resistance. And the definition for primary resistance is progression during the first 6 months of treatment. And this is typically seen in those with exon 9 mutations, those with the D842 or wild type GISTs. And we actually know this now since we often get mutational testing much earlier than was previously available over 10 years ago. For secondary mutations, it's really defined progression after 6 months of therapy, after having had an initial response with tumor reduction, and those are usually patients with primary mutations in exon 11. The exon 11 mutations, this is a good time to mention the different types of exon 11 mutations. They can be point mutations, substitutions, or duplications or deletions. The one group that is important to recognize are those with exon 11 deletions. And uniformly, this group of patients with deletions in their exon 11 of KIT really do much worse in terms of overall natural history. So again, here's just another pictogram where the mutations that we often see that are secondary are in these two areas, mostly in that activation loop, and sometimes in the ATP binding domain. What's interesting is with secondary mutations, it can happen in different mutations can happen in the same patient in different areas of the tumor. This is quite well described where tumors that have responded previously to imatinib, there are focal areas of resistance that can happen, and we can truly see areas of oligo progression. And that for those patients, we sometimes do consider local therapies rather than switching to a second or third line TKI. And for patients with, for example, exon 9 mutations, we do dose escalate their imatinib to about 800 milligrams of imatinib. So what about post-imatinib in terms of second line therapy? I'll just take you quickly through a couple of this or the main trial with sunitinib. This is, I believe, what's called a kinome, and it looks at the different receptor tyrosine kinases in humans. And what you can see with imatinib is tends to be fairly focused in terms of its inhibitory activity. But if you look at sunitinib on the right, it sort of has a broader activity in different areas as represented by the red circles. So this was a phase 3 trial of sunitinib in imatinib-resistant or intolerant, just conducted at almost 60 centers. And they took patients and randomized them to sunitinib or placebo at time of intolerance or progression. And the schedule that they used was 50 milligrams of sunitinib a day with 4 weeks on, 2 weeks off versus placebo given the same way. At that time, placebo was justified as there was no additional therapy, and then this allowed crossover from placebo to the drug sunitinib at time of progression. PFS was the primary endpoint in this trial, and as you can see, for the placebo arm, patients basically progressed at their first scan in 6 weeks compared to time to progression seen in at about 6 months for those with sunitinib. This resulted in the FDA approval of the drug sunitinib for just in 2006. However, what we have learned since then is that the dosing of sunitinib at 50 milligrams 4 weeks on, 2 weeks off is probably suboptimal, and most of us will recommend patients start at a dose of 37.5 milligrams once a day as continuous therapy. In fact, patients who are started on a 4 weeks on, 2 weeks off often report worsening of symptoms during their 2 weeks off the drug. And I think this is something that's seen in renal cell carcinoma also. What about third line therapy post sunitinib? Regorafenib is another TKI which also has broader activity than imatinib, or is what we call a dirtier TKI. And this, based on initial testing in the phase 1 setting, suggested it may have additional activity for those with GIST progressing on both imatinib and sunitinib. And this led to what we call the GRID study. And the GRID study was, again, a similar approach. It's a 2-to-1 randomization, and placebo was given because there was no standard of care. The dose of regorafenib is 160 milligrams 3 weeks on, 1 week off. Patients were either intolerant intolerant or progressing on both imatinib and sunitinib. This trial enrolled very quickly, and it only required the involvement of 17 countries. Again, people were allowed to cross over at time of progression if they were found to be on the placebo arm. This showed again a significant difference between the treatment and the placebo arm. You can see that most patients actually progress within 2 months, with half the patients progressing just at 1 month if you're on placebo. And this really shows sort of the aggressive nature of the disease once you start going beyond imatinib. So the difference was a hazard ratio of 0.27 between the treatment versus placebo, and the primary endpoint was clearly met. And as a result, the drug has been approved in the US, EU, as well as Canada, and subsequently funded in Canada for treatment of progressive disease post-imatinib and post-sunitinib. Unlike those with colorectal cancer, when we use regorafenib in this patient, we do not start them at a lower dose of 80 milligrams or 120. We actually start at 160 milligrams. And patients do tolerate it better than for those with colorectal cancer. And it's not clear why. It may be because of their prior TKI exposure, whereas those with colorectal cancer do not get treated with TKIs in general. But they do tolerate 160 milligrams for this disease. So it's amazing at this point. We are now talking about what happens post regorafenib, and this is where a new drug called ripretinib or Qinlock is coming into play. And ripretinib is a drug which is a switch kinase inhibitor and is specifically targeted to those that have mutations in exon 17 and 19, because it binds to both the activation switch and the switch pocket and locks it in the inhibitory state in terms of downstream growth factor signaling. This was studied in what's called the Invictus study design. And again, like many of the other trials, the randomization was 2-to-1. It was a modest sized trial of 129 patients. There were 2 stratifications factors, and placebo was the comparator, and ripretinib was dosed at a continuous dosing of 150 milligrams once a day. I think it's important to note that in the phase 1 setting, I do not think a MTD was found, but they decided based on initial data that 150 milligrams would be used continuously. This was a slightly more complicated design in that patients were allowed to cross over to ripretinib at time of progression if they were on placebo. But if they were on ripretinib at time of progression, they could undergo dose escalation to twice a day, continue the same dose, or actually study or stop study treatment. The primary endpoint was PFS, but it was by blinded independent central review, with ORR and overall safety, overall survival and safety being secondary endpoints. And as you can see, the trial is actually fairly recent, having been completed in 2019. And this was for those who've had 3 or more prior treatments. So I'm going to go into this trial a little more in detail. You can see that there were slightly more males in the patient population, which is reflective of the disease. About just over 50% had a performance stat of 1/2, and 2/3 of patients actually had 3 lines of therapy, and 1/3 of patients on both arms had 4 or more, and some as many as 7 other therapies before enrolling on the trial. There is some molecular data, and they've outlined those in terms of exon 9 and 11 mutations, with exon 11 being the most common. And you can see that there were very few patients with platelet-derived growth factor receptor mutations that were identified while on trial. There's the different sites of tumor on the bottom row. The primary endpoint was progression-free survival. You can see that consistent with other trials, the placebo is associated with a PFS of a median PFS of 1 month, i.e. half the patients progress at the time of their first assessment. And for ripretinib, it's actually 6.3 months in terms of median PFS. So if you look at the secondary endpoints, out of 85 patients who were randomized to the treatment arm, the response was seen in 10%. And on the placebo arm, no tumor responses were seen. The duration of response was actually pretty impressive at being over a year, at just over 14 months. And as you can see in the spider curve on the lower right side, those are the responders, that those who responded continued to respond for a pretty impressive amount of time, despite this being in the third or fourth line setting or later. The overall survival being a secondary endpoint, although there's crossover, it was significant with a 64% reduction in risk of death. It was not really evaluated for significance because of how the study was powered in terms of statistical plan, but we can see the differences as outlined in the graph above. This is actually pretty well tolerated. The most with grade 3-4 side effects being rare, mostly being grade 1 or 2 with alopecia. This drug probably has less PPE than the other drugs that in the second or third line setting. And the most common lab abnormalities is hypophosphatemia and a slight increase in lipase, most of it which is grade 2 or grade 1 or 2, and do not generally need dose modification. I wanted to show you this graph, as I stated at the outline of the Invictus study. Those who were on ripretinib once a day at time of dose escalation, they could be escalated to double dose because there was no safety concern with increasing the dose. And out of the 85 patients randomized to the ripretinib arm, 43 actually underwent dose escalation to twice a day. And from this data, there were no new safety signals. There were no additional tumor responders after the dose was escalated, but their second PFS was about 80% of the first PFS seen. And I think a quarter of the patients were actually remained in the double dose for greater than 6 months. So overall, this drug shows that it's clinically active with extending PFS versus placebo in the third and later line setting with tolerable side effects. There is a survival benefit, and the safety signals are consistent after longer term follow-up from the additional trial. And this drug has been approved in by Health Canada and has been recommended for funding by CADTH at this time. So what about ripretinib in an earlier line setting? I'll just briefly show you the INTRIGUE study. The study results were released earlier this year, and this was a second line study of ripretinib versus sunitinib in the second line setting, and the results suggest that they're similar in terms of median and progression-free survival being at about just over 6 months. So this was disappointing, but for now, the activity of ripretinib seems to be in the later line setting, which is currently available to our patients. What about other TKIs? The patient population that's been the most difficult to treat were the D842V mutations. And this drug, avapritinib, came to attention several years ago. And importantly, as you can see in the doses or the levels seen in the green, avapritinib, the IC50s are in the nanomolar range for the D842 mutants, as well as the other mutations, including exon 11 deletions, for which the treatment has been quite suboptimal. And there have been two studies that have been designed to look at the activity of this drug. One is the phase 1 study, Navigator, and then the Voyager study of avapritinib versus Rigo in the 3rd and 4th line setting. So I'm just going to take you through the subgroup analysis of the Navigator drug, which has led to this drug's approval. And this is the patient population is here. And there was a dose escalation part. Most of the patients were treated at 300 milligrams of avapritinib. And then the dose expansion part, there were 36 other patients treated for a total 56 patients with this mutation treated on this trial. Again, they had previously been treated with other TKIs. And what this showed is actually a pretty impressive waterfall plot. This is not commonly seen. I think at ESMO this year, some of the immunotherapies in colorectal cancer showed similar, even more impressive waterfall plots. But again, these are patients with the D842 mutation. As you can see, almost all the patients had reduction in tumor volume. And actually 49 of 56 patients had responded. And 5 of these, as you are actually complete responses, and 44 are partial responses. And this is a patient population where if we gave imatinib, sunitinib, or regorafenib, the graph would be completely flipped on its horizontal axis. So the as comparison, the response in the non-platelet derived growth factor mutations was only 17% compared to almost 90%. The overall survival at 3 years was 71% in this patient population. That being said, this patient population does do better than the other patients with other mutations. The toxicities of this drug are not insignificant, and they're a little unique compared to the other TKIs. Importantly, the one I want to point out is cognitive changes. So you do see cognitive changes in almost half the patients with deficiency in in short-term memory, as well as an occasional rare CNS bleed. So this requires active monitoring and dose modification in these patients. And I believe there's just another TKI in lung cancer that causes similar side effects. The Voyager study was in an earlier line, so really versus regorafenib in the 3rd line setting, 300 milligrams of avapritinib versus regorafenib. But this trial was reported out, and it did not meet its primary endpoint, with median PFS being actually a little bit inferior than regorafenib. So I think this drug is being targeted just for the D842V mutation. It is not yet approved in Canada. It is approved, I believe, in the EU and in the US. It has been available to some patients in Canada through the SAP setting, although it remains on hold right now in terms of drug availability from the sponsor. So what about other drugs? There is another drug I have not yet seen called crenolanib. It inhibits multiple kinases. It also seems to be active against the D842V mutations and has been studied in the phase 1/2 dose escalation setting, and is currently being studied in the D842 mutated GIST. I believe this trial is open in some centers in North America. 120 patients are being randomized to placebo versus crenolanib and first efficacy readouts are expected. So I'm going to take you through in the last 10 minutes is the role of local therapies in advanced disease. This is for a rare cancer, it's difficult to study because randomized trials are not really feasible. There are some limited retrospective series which suggest that surgical excision of progressive disease is not overall beneficial. But there are ways of attacking this, such as RFA, as well as bland embolizations that can be considered. And I would encourage that we need to individualize patient treatment decisions at a patient level. So I'm going to go through two cases. This is a 63-year-old woman who actually had a proximal gastrectomy in 2015. The tumor was small, but it had a very high mitotic rate. The patient went on adjuvant Gleevec, which was appropriate, but discontinued due to side effects after 3 months. And she actually recurred just at the 2-year interval with a local recurrence at the gastrohepatic ligament. The patient was started on sunitinib and had a number of toxicities, but the oncologist was able to get them through for a number of years until 2021. So 4 years later, when they experienced local progression of this disease and was referred actually to radiation oncology at Sunnybrook. And given that this is a radio insensitive tumor, there was no radiation possible or recommended, and the patient was discussed at the tumor board and surgery was not recommended. And as you can see in this, it's really a tumor right behind the liver and right neck proximal to the stomach. The patient was referred to myself, and we decided to start the patient on regorafenib. The patient at this time had a fair bit of pain requiring opioids. And we again discussed the patient at a different tumor board, and it was decided that this tumor may be resectable, given that the patient was already on third-line therapy and had limited disease in this area. And the patient went for an open liver resections with segments 2, 3, 4, and 1, and without the stomach having to be operated on just about a year ago now. And the pathology showed a recurrent GIST, not surprising, high mitosis, and an exon 17 mutation with which is commonly seen on previously treated therapies. And this is a mutation that's known to be sensitive to regorafenib. And since the surgery, now that it's been over a year, the patient has no visible disease on the current CT, and they remain on regorafenib 80 milligrams, 7 days on, 7 days off, a year later. So hopefully, with the ability to resect this tumor and being on regorafenib, the patient will live longer. Current patient is certainly living better at this time. The second is one of the last patients I actually saw at Odette. I saw this patient on Christmas Eve, I believe, in 2019. It was a 30-year-old woman who presented when she palpated a large mass in her abdomen during yoga. And this, her CT showed this large mass that was felt to be related to the duodenum, and she had at least 10 liver lesions at the time. She underwent an US biopsy in early January, which showed a spindle cell tumor that was CD117 and DOG1 positive. Mutational analysis revealed an exon 11 deletion. And again, exon 11 patients do worse overall. And she was placed on imatinib and had excellent response, especially in her liver. Almost all the lesions in the liver became just completely cystic, and such that the radiologists were just calling it plain cysts in the liver. The primary tumor also did shrink, as you can see, but it still remained quite solid. And so after 18 months of therapy, we discussed whether she should have an attempt at a resection of the primary tumor. And after discussion with the patient amongst the surgeons, it was decided the patient did undergo surgery with partial duodenal resection. She did not need a Whipple procedure and had the section 2-3 resected and remains on imatinib. And what I want to show is, sorry, I can't go back. is in the ESMO guidelines. You can see excision and ablation of the tumor is reasonable when there's limited progression. Although she doesn't technically fall into this because there was no progression, I was concerned that given the location and the modest, the significant tumor that remained in the duodenum, that we should consider surgery. This is what her tumor looks like now. So this is her cystic metastases. But what's now happening is you can just see a little bit of tumor growth in this area in one of the cystic tumors. And I suspect that it's probably a secondary mutation with probably mutations in exon 17 or 18. And for right now, I'm planning to increase the dose of imatinib. And we will consider in the future, if it remains quite limited, whether we should treat these locally or whether I need to switch therapy beyond increasing the dose of imatinib. So in terms of new drugs approved for GIST, we started with imatinib in 2002, Sutent or sunitinib in 2006. 7 years later, regorafenib, and 2020 has been a good year for GIST, with ripretinib being approved in the third or the fourth line setting in Canada. Avapritinib is not yet available. It's not clear what will happen in terms of regulatory approval, but it is approved in the US. But hopefully this becomes available for our patients. And of course, in 2022 is when the great Roger Federer retired after 20 Grand Slam wins. And that was, I believe, only like 3 weeks ago. So a lot of progress made, not quite as, I would say, maybe more glorious than Roger's career in the field of GIST. And I'll leave it at that. Thank you.
Thank you, Dr. Cole, for that excellent overview. Are there any questions from the audience? I can start with the first question. Is there any evidence for drug holidays for these patients, given the indolent nature of the tumor? I ask because I have a patient who was known to you before, who's been on imatinib for almost like over 10 years now.
Yes, so the data suggests no. The French did a trial of imatinib to best response, and at time of best response randomized them to stopping imatinib